All right, so, when we hear CMC, fracture dislocations or metacarpal base, we often think about Bennett fractures or Rolando fractures of the thumb, and there's been so much written about that in the literature that I actually decided not to talk about the thumb today and just to talk about index, long ring, and small finger metacarpal base fractures and fracture dislocations, and particularly with a focus on avoiding complications. So, as Dr. Littler, stated, the CMC joints form this fixed unit of the wrist. We have both a longitudinal arch, including the first and second metacarpal bases and the distal carpal row, which allows us to have a very sort of gross and powerful grip, but also fine finger movements as well. And then there's this sort of fixed transverse arch, which is the bases of all the 5 metacarpals with the distal carpal row. So you have the fixed base and then the adaptive MCP joints. The index and long are obviously, much more fixed in position compared to the ring and the small finger, with particularly the third CMC joint, which is this rigid axis, the keystone of the wrist. There's numerous ligaments, 9 dorsal ligaments, 11 volar ligaments. There's a lot of interosseous, intermetacarpal ligaments stabilizing the CMC joints. So, these are, relatively rare compared to other types of hand trauma. Usually the mechanism has to do with axial loading, typically from a misplaced punch or potentially a well-placed punch, I guess. High energy MVAs. Also forced flexion of the wrist with the arm extended is a common cause, particularly of index and long finger metacarpal base fracture dislocations. The index and long are more rare in general. Little and ring finger metacarpal base fracture dislocations are much more common. So the management of this includes sort of the spectrum. So there are some authors, we'll get into some of the evidence later, that demonstrate that sometimes these can be successfully treated with closed reduction, but many times these are unstable, and therefore we look at surgical management, usually with open reduction, and then fixation of the fractures with numerous different modalities. We can do lag screws, we can do K-wires, we can do direct plating, sometimes plates that span the CMC joint. And then once the fractures are fixed, we have to look at the joint and determine if the joint is stable or remains unstable. If it remains unstable, then we should supplement that with a temporary K-wire. So these can sometimes be an issue, particularly when they come through the ED and they're evaluated by ED staff. They can be misdiagnosed. This is a good teaching point for our trainees, to always look at all the different views very critically. If you're just looking at, say, a AP view like this, they can be easy to miss. But when they are missed, it leads to a lot of complications, including malunion, residual dislocation or subluxation, hand deformities, pain, and ultimately osteoarthritis at the CMC joint and long-term loss of grip strength and range of motion. So it's very important that we diagnose these accurately. So I'm going to start with index metacarpal base fractures and fracture dislocations. These are relatively rare, as I mentioned. Most of the literature focuses on just isolated case reports and a few small series. So in theory, you can imagine if it's just purely a fracture of the articular surface, since there's not that much motion at the CMC joint, does it really matter if we get like perfect joint congruency? But what I'll get into in the next slide is some authors have shown that a lot of times these are unstable. So if there's a fracture dislocation, you're going to get ECR pull, and that can make it very difficult to have a stable closed treatment of these fractures. So most studies recommend open reduction with at least K-wire stabilization. So back, many decades ago, as I was mentioning, some people thought that these did not result in a lot of disability and closed treatment was recommended, but then subsequent studies showed that it can be very difficult to maintain closed reduction, reduction with closed methods. This study from 1987, Journal of Hand Surgery, showed that if the ECRL is avulsed in that particular situation, that's something that really needs to be noted early on and addressed surgically. Because even as early as 12 days afterwards, these authors found that they were not able to advance the ECRL and get reattachment. So in those series, that and another series where the ECRL did not end up getting fixed, they did note significant morbidity with decreased grip strength without an anatomic tendon repair. There was another study with a small series of ECRL avulsions that ended up being treated closed, and that resulted in weak dorsiflexion, a painful bony prominence that eventually required surgical removal. So the overall recommendation is to, I think, be more aggressive, treat these with open reduction, internal fixation of the fracture, and anatomic fixation of the tendon whenever there's a ECRL tendon avulsion. And again, so this was, I put this paper in here because I thought it was an additional sort of alternate treatment that I hadn't really done in my practice. So this is using external fixation for treatment of index metacarpal-based fracture dislocations. I just thought it was an interesting series. They actually had one of the larger series of 10 patients, and they treated these fracture dislocations with closed reduction and external fixation. They did find no difference ultimately in grip strength or pinch strength with the contralateral hand or PIP and DIP flexion, but there were some differences in active motion scores and quick dash scores, and there was one patient in that series with post-traumatic arthritis. So I just thought it was an interesting alternative treatment for this situation. So moving on from index to long finger metacarpal-based fractures. So these are also quite rare. Usually, again, the result of a forced flexion moment at the wrist when the wrist is held extended, and usually with the arm extended and with a clenched fist. So most studies would recommend to be aggressive with these and to do surgical repair of intra-articular fractures. ECRB is inserting on here, so that's going to make these fracture dislocations very unstable. So fix the fractures with plates or lag screws. You can also get ECRB avulsions, and this is a case report of a 32-year-old man with an avulsion fracture of the base of the long finger metacarpal. Not only was there an avulsion fracture, but the ECRB tendon was actually avulsed from the fracture fragment itself. So this had to be treated with open reduction and internal fixation with an additional suture anchor for the tendon reattachment. So this is, again, something to sort of keep in the back of your mind to avoid these potential complications when you're treating these kind of more unusual injuries. So moving on from long finger now to the ulnar ring and small finger, we kind of treat those kind of as a group, mainly because isolated ring finger CMC joint fracture dislocations are quite rare. They're not non-existent, but they're quite rare. They tend to occur almost always in conjunction with a fifth metacarpal base fracture. So your surgical options with ulnar metacarpal-based fracture dislocations are closed reduction and casting, closed reduction percutaneous pinning, and open reduction and internal fixation, those methods that we've already kind of described, particularly if you're using plates with either a dorsal buttress or bridging of the CMC joint. So I wanted to see what's out there in the literature. This was one of the larger studies that I could find, which kind of is an attempt at a meta-analysis of all the outcomes out there for these types of fractures. There weren't enough studies that could be included to do a true meta-analysis, so it's just an analysis. They had 6 studies that were included, 90 patients, and these are the surgical management options, which I thought was interesting. 11% CRPP, 31% open reduction, percutaneous pinning, 8.9% ORIF with CMC bridging, and 16.7% with open reduction with a dorsal buttress plate. But interestingly, a third treated with closed reduction only. So all the patients that were surgically managed that they found in this study had a 0% non-union rate. So these fractures tend to heal. But some studies did show decreased grip strength, but on measurement. But this did not appear functionally significant. I think out of all these studies, there was only one patient that could not return back to work. So the complication rate. So the theme of this talk is to avoid complications. So there's a 14% complication rate across all these patients. Higher complication rates in those patients who received a plate and screw constructs, but typically those are going to be done for the more comminuted and complicated fracture patterns. So that's something that might be expected. Something to know is that when there is a complication with a plate and screw construct, those symptoms typically will resolve with removal of the hardware later on. So that's something that is good to know ahead of time so you can counsel your patients. So this is another study looking at timing of treatment as well as the type of treatment. So these were a series of patients that were presenting with both acute instability for fourth and fifth CMC joint dislocations, as well as a group of patients that presented later with chronic instability. So there were 20 patients that presented acutely. Their definition of acutely was less than 3 days with fourth and fifth metacarpal base fracture dislocations. These were treated all with just closed reduction. And they actually had pretty good outcomes with that. So the MHQ, 98, there was no range of motion or grip strength differences compared to the non-injured side. And sensation, return to work, and fine motor movements were unchanged, and there were no incidents of post-traumatic arthritis. Patients that are presenting greater than 2 weeks with unstable CMC joints, there were only 6 people in that group, and half of them were treated with surgery, half of them were treated closed reduction alone. And the ones that were treated with surgery also did very well. So this shows you that these patients can do well even if they're presenting late. So the MHQ scores are 96. Again, no significant difference with grip and range of motion, and the sensation, return to work, and fine motor movements also unchanged, and no post-traumatic arthritis. But the patients that were treated only with closed reduction, who were presenting 2 weeks out or later, had much poorer outcomes with a 40% grip strength loss and 2 patients with post-traumatic arthritis. So the take-homes from this is that we need to avoid delays in diagnosis, and this extends to making sure that these are identified properly in the emergency department with the initial workup. And the take-home point is that if you have chronic instability, those should be treated surgically. But the patients that are presenting acutely can potentially do well with closed reduction. Obviously, depending on the fracture pattern, if they have something that's obviously unstable, you're still going to want to treat that with surgery. There was another study here looking at fourth and fifth CMC joint fracture dislocations and trying to compare a series of plating the fractures just directly with the metacarpal base, or a plate that spans the CMC joint onto the hamate. And I include this study mostly because it's the largest series, and it's one of the only prospective randomized studies out there looking at this type of injury. So this was a series of 100 patients with these fracture dislocations, and they were randomized to either transarticular fixation or non-transarticular fixation. You can see examples of each in the photos there. So we've got a plate that spans the joint with screws into the hamate, and then one that's just addressing the base of metacarpal fractures, and then treating any coronal hamate fracture independently with a screw. So the results. So there was no difference in fracture healing time between these two groups. However, after 6 months, even though there wasn't a difference in grip strength, what was noted was that the patients who had transarticular plates could not their range of motion at the fourth and fifth CMC joint was limited, and so in that series, all the hardware ended up being removed from those patients, and they ended up doing well afterwards, but it required that second surgery. But to note, even I think it was approximately half the patients in the group that had non-transarticular plating also had their hardware removed for different types of hardware irritation or complications as well. So you can achieve good fracture fixation and healing with both of these methods. Why would you do transarticular fixation? Well, the benefit is that it acts as a buttress, so you can know right away that you're going to have very little risk of redislocation or subluxation of that metacarpal base. So some other kind of edge cases I thought were interesting to review, for this talk in terms of just having a high index of suspicion of potential complications. So I found a couple cases of acute carpal tunnel with these metacarpal-based fractures. Not something that we might typically associate with this type of injury, but in this case, there was a 24-year-old man who punched a wall. He presented with dysesthesias of the median nerve, and there was typical signs and symptoms of acute carpal tunnel. So he was treated, and what was noted on workup was that fracture fragment came off the volar base of the metacarpal and was in the carpal tunnel, directly pushing on the median nerve. So something that's pretty rare, but just to sort of keep in the back of your mind that don't ignore signs and symptoms of carpal tunnel syndrome in these types of fractures. So ended up being treated and healed well. So carpal tunnel syndrome, acute carpal tunnel syndrome in metacarpal fractures is, again, fairly rare. There's an old paper from the 70s that showed that it can be present with volar fracture dislocations in the second and third metacarpal bases because they're right at the distal point of the carpal tunnel. And then a more recent paper from 2008 showed that acute carpal tunnel could be associated when you have multiple metacarpal fractures and severe hand swelling. So definitely have a high index of suspicion and really pay attention to the sensory exam. Another complication that you might not immediately think about when you're treating these patients is ulnar nerve injury. So there is a risk. There's been a number of patients that have shown that there is a risk of iatrogenic ulnar motor nerve injury with dorsal fixation of fourth and fifth CMC fracture dislocations and in particular coronal hamate body fractures. And this was attributed due to either K-wire or drill bits kind of passing quickly through the hamate or the metacarpal bases and passing through the volar cortex and injuring the motor branch of the ulnar nerve, which runs in close proximity. So there was this very interesting anatomic study by Peter Taub's group from last year, which looked at 10 cadaver hands. They did a dorsal approach. They exposed the dorsal hamate and the fifth metacarpal base. They divided the hamate into quadrants. Basically, the vertical line was in line with the separation between the fourth and fifth metacarpal, and then horizontally just splitting the hamate in line with the distal carpal row. And then also they exposed the base of the fifth metacarpal. They drilled holes in each quadrant of the hamate as well as the metacarpal base about 5 millimeters proximal to the articular surface in the dorsal midline. And then they put screws in, which were with about 5 millimeters of overshoot past the volar cortex. And then they turned it over and looked and exposed everything and see what they saw. Now this picture kind of gives me anxiety. You see here that actually, so so you see here the screw tips from the hamate are actually like fairly far away. Here's the ulnar motor nerve, here's the ulnar sensory nerve, here's the hook of the hamate and the body of the hamate here. So the 4 screws from the 4 quadrants of the hamate are fairly, far away and relatively safe, but the fifth metacarpal screw tip, look at that, it's right there. So they found that 6 out of the 10 screw tips from the fifth metacarpal abutted the ulnar nerve, and then the rest of them were actually within 1 millimeter. So use extreme caution if you're K-wiring or drilling the base of the fifth metacarpal in a pure dorsal to volar direction. In fact, I would, and then the conclusion of this paper was don't do that. Use a more oblique angle starting at sort of the ulnar cortex and then going down into the hamate to try to avoid this complication. All right, so those were just some different potential complications, and thanks for your attention.